last year with my job to get to meet her and know her better, and so we kind of learned a lot about each other. And so she said, yeah, when I first asked her a long time ago, was she willing to do this, she agreed wholeheartedly, and now the day has come. She's gotten me another speaker lined up for a few months down the road, and Caroline is also going to speak. So they're going to tag team. Sorry, I don't know your bio about, but you're going to be coming back doing another one. So they will both be back and participating. So she's going to talk about COPD, and as we've talked over the last year or so with the different diseases, when you have questions, you will be able to ask them at the end. But then when we find those 2 or 3 people who want to talk about sleep, then we'll bring another speaker in, and we'll kind of do it. It won't affect everybody, but all's fair, to get every disease we can possibly cover. So, well, here's Beth, and I appreciate it. Thank you.
Thanks for having me. So I'm going to talk a little bit about, why we care about COPD, and how it affects the lungs, affects the heart. I'm going to talk about how we diagnose it,
We're out of change
and what
already.
treatment options there are. We have a video that I'm going to show you in the beginning part. Hopefully, we checked it and the volume seems okay, so hopefully you'll be able to hear that okay. Okay, so again, my name is Beth and this is Caroline. So COPD, what is COPD? What does it stand for? A lot of people hear those letters. We had someone say the A, B, C, D, hear these acronyms and wonder why do we say them, what do they mean? So chronic obstructive pulmonary disease. COPD and asthma are similar in some of those respects, and they're both obstructive lung disease. I heard a few of you say that you had asthma, meaning you get air in but have a hard time getting it out. And so other diseases you'll hear that go along with COPD are sometimes used interchangeably: emphysema, chronic bronchitis, and again, the way that asthma and COPD can be very similar, that they have inflammation and obstruction as the main component, airflow obstruction. So why do we care about it? Well, it's the 3rd leading cause of death in the United States. It causes a significant amount of mortality and morbidity for patients. So we certainly want to catch it early, treat it effectively, and help patients lead a longer, happier, healthier life. And interestingly enough, although it tends to affect, gender pretty equally, women tend to die more from COPD than men. And this is just a short introductory video about what COPD is, and it has some really good graphics of the lungs and the inside of the lungs to kind of explain with visual cues as well what happens with COPD and why it affects the lungs the way that it does. So hopefully this will come out okay.
Understanding chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure such as wood smoke can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, it requires much more energy, and it can get harder to exercise or do muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped. There are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs, and makes breathing more difficult. COPD is the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
So again, to kind of review some of what the video said, what is COPD? You get inflammation and swelling of the airway, and it causes it to be narrow. You get increased mucus production, so not only does the airway get smaller because of the swelling and inflammation, but you get mucus clogging part of it as well. As you saw there, they kind of like a bunch of grapes, those alveoli, those air sacs. That's really where all of the business of the lungs take place. That's probably the most important part of the lung. It's where you get your oxygen from the lung into the bloodstream and get your carbon dioxide back into the lung that you exhale out. Particularly in emphysema, but in COPD in general, you get damage to that part of the lung. As you saw, the alveoli became kind of broken. Instead of lots of tiny air sacs, they become thin and break, and you get a few larger air sacs. They don't work as effectively, and air gets trapped. That's why we call COPD asthma an obstructive disease. It's not, people say, I can't breathe. It's not so much that you can't take a deep breath in, is that there's so much old air, there's no room for the new air. You don't have room to get that fresh air in because you can't get the old air out. It's like trying to fill up a room that's already, full of helium. They can only hold so much. So again, you have difficulty getting fresh air in, you get a sense of shortness of breath, cough, and then you also have wheezing. When you have that airway that gets narrowed and inflamed, you're going to get wheezing as you try to get a certain force of air through a very small airway. So what causes COPD? As you saw in the video, smoking is the leading cause of COPD. It's also a completely modifiable risk factor, and it's never, ever too late to quit smoking. Long-term exposure to irritants is another important cause. So if you work factory worker, work around asbestos, work around other smoke, chemicals, irritants, things like that. Certain dusty environments, wood chip environments, small inhalants and particles that you inhale that can irritate the lungs. That can lead to COPD in some cases. And then a less common cause, but certainly important, is something called alpha-1 antitrypsin deficiency. is associated with COPD and emphysema in particular. And that typically affects people that have, not necessarily any exposure to smoke or either or family history of lung disease necessarily, but they have this genetic disorder. And they're actually support groups specific to people that have lung disease from alpha-1 antitrypsin deficiency. So symptoms of COPD. Shortness of breath is the main symptom that people will in general present with. Wheezing. You may feel chest tightness or kind of a fullness sensation in the chest. As the disease really progresses, you might hear the term barrel chest, where the chest actually changes shape because the lungs become so full of air it pushes the rib cage out, and you'll have kind of a wide-looking chest from front to back. Chronic mucus production is just feeling in general fatigued and run down. So early signs of COPD, kind of that cough that just won't go away, or I've been struggling with this cold for 3 or 4 months. It may not be a cold that you're struggling with, it may be early signs of COPD. Also, for any smokers out there, people talk about the smoker's cough, or my daily cough in the morning. I always cough in the morning. There's no such thing as a normal daily cough. There's no such thing as the normal smoker's cough. It's not normal to cough every day. It's not normal to cough every morning. It's not normal to have mucus production all the time. If you have some of those symptoms, you need to get seen and try to determine, is it due to COPD or a host of other lung issues that may cause chronic cough. Early detection, getting in and seeing a medical provider is essential to make sure that you have good outcomes. The earlier you get seen, the earlier you get diagnosed, you can start treatment therapies. COPD is progressive and there isn't a cure, but there are ways that we can maintain lung function. So instead of your lung function declining like this, we change that level of lung function decline to a very slight slope down, and you're able to preserve your activity level and your lifestyle for much longer. And patients that are caught early and have fairly mild COPD, if they caught early, if they treat their modifiable risk factors, avoiding smoking, avoiding secondhand smoke exposure, staying active, you can lead a fairly normal life. Now, will you be able to run a marathon or do an Ironman? Maybe not, but there's no reason why you can't get out and do the things that you enjoy, go shopping, spend time with family, things like that. So I'm going to turn this part of the section of the talk over to Caroline, who's going to talk about what we do in our COPD clinic and how we diagnose COPD. And when you have your diagnosis, then what the next steps are.
So before I start talking about this, I will give you all a quick background on me, and not to break this podium. I started at Pulmonary Associates last year. Before that, I worked as a nurse in the emergency department at VCU for about 5 years, and came to Pulmonary Associates through a clinical rotation and just really loved it there. And as an ER nurse, we saw patients with COPD in the emergency department all the time, which sort of led me to be really interested in starting this clinic. So the way COPD gets diagnosed is, there's a few different ways. One is you can see a healthcare provider, such as your primary care. This happens with a decent number of my patients, who they'll say, okay, this person smoked, they're starting to feel short of breath, and they seem to be responding well to this inhaler. I think you have COPD. Sometimes you will have a chronic cough, or you'll have bronchitis a few times a year, and a healthcare provider will go ahead and say, all right, I'm comfortable just making a clinical diagnosis based on your symptoms and the things that you're telling me, you have COPD. Then there are folks who are in the pulmonary world, like myself, who specialize, would rather have a pulmonary function test or some imaging to confirm that diagnosis. So with a pulmonary function test, you either do spirometry or you sit in the booth and you do your complete pulmonary function test. And that lets us know some information about how much air you can take in your lungs, what your lung capacity is, how hard you can blow that air out, how much air you're holding on to. And it lets us know a lot of information about your lung volumes for us to say, yeah, this is COPD, or maybe this isn't COPD, maybe it's another lung process that we need to look into to make sure that we're treating it correctly. The last way that we can diagnose COPD is with imaging, so a CT scan or a chest x-ray. There are certain changes that will show up on those radiographic images that are consistent with COPD. So I've mentioned spirometry. Why is that important? Well, again, it's important because there are different conditions that can cause you to feel short-winded. One of those is heart failure. Pulmonary fibrosis can also cause you to have a cough. It can cause you to have a difficult time going about your activities of daily living. Asthma, acid reflux, allergies and sarcoidosis can also influence the way that you're breathing. So the spirometry and the pulmonary function test, they really let us know, okay, we're on the right track, we're treating the correct condition. So once you have that COPD diagnosis, how is that managed? The first thing that we counsel people to do, if they are still smoking, is to stop smoking. I try to have a really frank and realistic conversation with my patients because some people are in a place where they want to quit and some people aren't. My job is to let you know that quitting smoking is the first and biggest thing that you can do. But if you don't want to do it, we're still going to be there for you. We're still going to manage you. We're still going to give you medications. But this is the first biggest thing that you can do to modify the course of your COPD. The other thing that you can do is avoid secondhand smoke and other respiratory irritants. So avoiding allergens. If you know that you are allergic to cats and dogs, then trying to avoid having your cat or dog sleeping in bed with you is a great thing to do. Making sure that if you mow the grass and you're allergic to grass, that you're wearing a mask. Doing things like that to kind of head things off at the pass. Then we get into inhalers. There are two big different groups of inhaled medicines, and I think they can be sort of overwhelming. I was certainly overwhelmed when I first started learning them, but by keeping these broad categories in mind, I think it helps make them a little bit more manageable. So there's short-acting medicines and long-acting medicines. The short-acting inhalers are what we often call rescue inhalers, and they come on quickly and they wear off quickly. There are two very common medications in this particular segment of inhaled medications. One is albuterol, and that's what most everybody is on. The other option is called levoalbuterol or Zopanex, and some people who have a lot of heart palpitations, if they do their albuterol, they do better with Zopanex or levoalbuterol. So those are the short-acting medicines. You use them either when you're feeling short of breath or before you know that you're going to do something that makes you really short of breath. So some folks, I tell my patients, if you get really short-winded when you are taking a shower in the morning, feel free to do a neb treatment beforehand, because that'll kind of help open you up and give you an extra kick to get through your shower, or to get through making your bed or folding your laundry. On the other hand, there are long-acting medicines, or maintenance inhalers. And those are medicines that we ask our patients to do every single day, whether they're feeling good or bad. Those medicines, there are sort of three broad categories there too. There are long-acting beta agonists, which is a fancy term for it opens up your lungs over the course of the day. They work similar to albuterol. And then there's long-acting anticholinergics, so that's something like your Spiriva. And those medicines are meant to help decrease inflammation and dry up secretions. So before, when we talked about how in COPD some people get a lot of mucus in their lungs and they seem to always be coughing something up, Spiriva is meant to help with that. The other broad category under the long-acting medications are inhaled corticosteroids. Those also help decrease inflammation and dry up secretions. And the point of all of those medicines is throughout the day to open up your lungs and try to keep you from coughing as much as possible. There are other oral medicines that we use in addition to inhaled medicines. One of them is prednisone, which you all are likely all familiar with, for better or worse. And prednisone sort of helps decrease inflammation. It helps dry up secretions as well. Another medicine that is a bit newer is called Daliresp. And Daliresp works to modify the immune system's response, and it is meant to help decrease the number of times that you have an exacerbation, which is when you get sick. You know, you wind up needing antibiotics or steroids or something like that. There's pulmonary rehab is mostly an exercise program for people who have lung disease. There's a great program at Chippenham. Health South has a wonderful inpatient pulmonary rehab program. We also refer our patients to a lot of home health agencies. James River has a dedicated COPD program. I think Medihome also has a dedicated COPD program. And those sort of rehab programs help teach patients how to work through shortness of breath. They teach you breathing exercises to work through those times. And they teach you exercises to increase your activity tolerance. So being diagnosed with COPD doesn't mean, okay, I'm not going to be able to do these things. It means I'm going to learn how to do these certain exercises so that I can work through my shortness of breath so that I can do most of the things I want to do, or so that I can adapt the things I want to do to my current lifestyle. Oxygen is something that we use a lot in folks with COPD. We also use positive airway pressure devices. So that can mean a CPAP or a BiPAP, or there are other respiratory devices that, there's a Trilogy device, there's also a device called Astral, and those devices help take some of the work of breathing off the patient, and they help blow your airway open and pull the air back out, for lack of a better description. And those are all things that we use to help maintain your quality of life, help keep you at home, and help keep you feeling good. Other things that we like to do when we're managing COPD is make sure folks are eating a lot of high fiber foods, getting fresh vegetables, making sure that you're staying hydrated. I have to talk to a lot of my patients about how important it is to get water, even if you're on a fluid restriction because you have heart failure, making sure that you get the right amount of water every day.